the Demystifying NHS Finance for resident doctors. My name's AK. I'm an anaesthetist by background, and I'm my side role is I'm also a clinical lead for the One NHS Finance program, which is one aspect of which is educating non-finance people about the world of finance in the NHS. So I'm going to try and share some slides. I'm going to try and make this as interactive as possible. It is not the most riveting of subjects, but we'll try and make it interesting and relevant and useful. Right, I'm hoping now you can see all the different slides. Okay, there we go. Right, let's see if this. So as a way of starting off, if you could just put in the chat box what your specialty is, just so I can get a bit of understanding of the kind of spread of people we have here. It means that I can go into more or less detail into different aspects of the NHS. We've got a complete mix. Okay. Again. So the purpose of today is I'm not going to try and solve the financial problems that the NHS has. I'm not going to be able to tell you about all the intricacies and specifications of your local system. What we're going to try and do is give you some basic understanding of how the NHS works in England, and give you some of the tools to kind of go away and look at how your own systems work, and be able to navigate the system, the healthcare system, from a financial perspective, to help you understand some of the decisions that are made in your different organisations. So that's the main purpose of today. It is always about being clinically driven, but it's about understanding that every decision we make as doctors, as clinicians, has a financial implication. And so that is the purpose of today, is to kind of be aware of the financial implications, but clinically driven decision making will always be the priority. Okay, and we wouldn't want you to change from that. So the kind of things we're going to cover are a bit about the extra NHS structure, how services are paid for, so how the different bits of your services are paid for, a little bit about costing and plex, which is more relevant. It's relevant to everybody, but it will be of particular relevance to those in secondary care, to be honest. And the final thing is about business cases in the NHS and how they work. Feel free to ask questions as we go along. I'll try and stop at the end of every section to kind of have some questions. We are going to have a couple of breaks throughout the session, because otherwise you're going to get sick of talking to me, of me talking. Yeah, let's go. So the first thing we're going to talk about is when we talk about finance and working in a finite system, so where there's limited amount of money in the system, unlike some of the private healthcare systems in America, where it's not really finite. We work within budgets, we work within limited resources. It's more resources than some other parts of the world, but they are still limited. So what we try and do with that money is generate the best value that we can. Okay, so that's what you'll hear lots of discussions about value in healthcare, value-based healthcare, different connotations of that. But in order to do this properly, we have to understand what value in healthcare actually means. Now, there are three different types of value when we're talking about value in healthcare. There's something called allocative value, and that's how you divide up the resources that you have. So you've been given X amount of money or X number of staff, and it's how you then divide that up. Okay. It's mostly done at national level, at kind of regional level, and a little bit at organizational level. It's not really what we tend to do as clinicians. Okay. So allocative value is also called economic value. Okay. What we will be focusing on is something called technical value. So you've been allocated some resources, some money or some staff, and it's how you make best use of them. Okay. So that's what technical value is all about. And we're going to go into more detail because that's what's relevant to us. We often don't determine what our budgets are, but we have to then work within them. Okay. Also called efficient value. The last thing is, when we're talking about value, there is this extra bit. It's called personalized value. And it's that understanding, appreciation that what I think is important, what you think is important, and what our patients think is important may differ. Okay. Now, the two examples, and a lot of my examples are secondary care based, and I apologise for that, but that's the experiences that I have, and these are true kind of stories. So the academic example is there was a health board in Wales that has worked with the Virginia Mason Institute, which is an American kind of healthcare system, and they're really big on value-based healthcare. Okay, and they did a study where they looked at clinicians or doctors out what they were hoping to achieve out of a consultation. This was in a neurology clinic, and they asked the same thing from patients. Okay, so the clinicians, the doctors, wanted to diagnose, reduce, prevent disease progression, and treat the condition. Okay, so that was their focus. The patients wanted better sleep, more energy, to be able to go out and play with their kids or grandchildren. Okay. Now, most of the time, those things align, but not always. And it's that understanding that there are differences in people's values. Okay. I do a high-risk clinic for bowel cancer, for anaesthetics, and I see patients who are well, they're functioning very well, so they're doing all the things they want to do, they're living life and having a good quality of life. And you tell them that they may not be able to get back to that quality of life. Okay. Now, some people go, that's fine. The thought of having cancer, I'm willing to take that risk. I want to get this done. I want to get this done. I want to get it done, dusted. But at the other end of the spectrum, there are people that go, look, my enjoyment in life is walking my dogs, and if I can't walk my dogs for even for 6 months or a year, these are people often in their 80s, and they go, actually, I'd rather take my chances and enjoy the time I've got left. Okay. And so different people have different values. It's not for me to say whether it's worth them taking the risk or not. Okay. So it's just that understanding that even within value in healthcare and the finance world, it is about choices and priorities. Okay. So, as I said, we're going to focus on value as in the technical value, how we best make use of the resources. So if we were to write value as an equation, what one word would be on the top line and what one word would be on the bottom line? Value equals something over something.
It'd be something like how much you put in and over how much you get out.
Yeah, but I want one word for the top and one word for the bottom. It's just to
Benef-
make you think and as I said, make it a little bit more interactive than
Benefit over cost.
benefit over cost. Okay,
Output over cost.
pardon?
Output over cost.
Output. Yeah. So you're all right in many ways. So cost is the bottom line. There is a better word for the top line.
Quality.
Quality. Yeah. So quality. So quality over cost. Okay. So a lot of if you look at a lot of finance papers and um, some of the older papers that would look at value, they will use outcome over cost. Okay. Now we've shifted to look at value, to look at quality, because it is a more accurate representation of what things, the components that we need to look at. All right. So the next question, okay, and for those of you who are looking at getting consultant jobs or something in the future, this does come up in consultant interviews. What are the three domains of quality? There are three different areas, three domains of quality. Most of your organisations will have a quality commitment. They'll have, and they'll cover these three areas. It's in the NHS Constitution and in some of the legislation. So, what are the three domains of quality?
Not aware of the domains in the NHS Constitution, but the Institute of Medicine said that there were 6 domains of healthcare quality, and that was making sure it's safe, effective, patient-centered, timely, efficient, and equitable.
Yeah. So that's what you probably have the CQC kind of version of it, but there are, if you want to put it into a much broader sense, just makes it easier. And this helps when you're doing your business cases. There are three domains of quality. So these are the NHS's three domains. So a lot of the other stuff is done is at international level, but in the NHS there are three domains. You've kind of covered most of them, but just for completeness, let's see if we can think of any. So which of those three would you think were the most important then? Which of those six, sorry.
Probably safe and effective, and
Okay.
I'm not sure what the 3 you'd pick out the 6.
Yeah. So effective. So we can call effective clinical outcome. Okay. So one of the domains is outcome. Now there isn't a specific outcome when you're looking at this. Okay. It could be anything from mortality, quality adjusted life years. It could be readmission rates. It could be any. You've got to choose the most suitable metric for the thing that you are trying to demonstrate. Okay. When it comes to outcomes. And because not all the sometimes the outcome you need is the one that's not easily measured. Okay. So an example we have is okay. Big laparotomy wounds, so big cuts in the abdomen. There are different ways of closing the abdomen. There's one way that adds an extra half an hour onto surgery. Doesn't affect length of stay, doesn't affect pain, doesn't affect kind of 30-day mortality or immediate complications or anything like that. None of the standard metrics would be met or would be affected by this, but it does reduce your productivity because it takes an extra half an hour. What it does do is reduce the rate of incisional hernias, okay, in that wound by about 50-60% over 5-10 years. So over a longer term time period, it's shown to be beneficial. And those complications, incisional hernia repairs, are a pain to deal with and quite expensive to deal with. So if you were to use any of the standard metrics that we would normally use, it wouldn't show any differences. So you have to pick the right metric to demonstrate the outcome you want. Okay, so clinical outcome. Patient experience. Okay, so that's a really important one. You've got to show that you're not going to negatively affect that. And patient safety. Okay. There are other things that people talk about, staff experiences and things like that. They are directly they directly affect those three. They're not a domain in itself, but they are they directly impact patient safety and patient experience and clinical outcomes. Okay. So the costs are generally divided into two. Okay. You've got your revenue costs, which are your day-to-day running costs, repeated. They kind of, salaries, consumables. They're the kind of repeatable costs, day-to-day costs. And your capital costs are your one-off big purchases. Okay. So you'll find that when you're looking at costs and when you're trying to look at buying stuff, you've got to work out, is it going to be a revenue cost or a capital cost? Okay. Now, the guy that came up with this years ago, Michael Porter, who's a Harvard business professor, there were two purposes for this equation. One is that you have to demonstrate, so when you're doing a business proposal or any kind of improvement project, you have to show that the improvement in quality is worth the cost. Okay, so you have to show that the improvement in quality is worth the cost. So every year or every 5-10 years, we can bulldoze every hospital and build a new one. Now, it would improve the quality in some places more than others, but it would probably not be worth the cost. Okay. In some instances, it would be. Okay. The other thing that he said was that generally, if you improve quality, you will reduce costs. The problem being, it's what kind of costs are you talking about? It may not be your revenue or capital costs. It may not be the cost to your department. It may not be the cost to your organization. It may be cost to other organizations, like you might do things that have beneficial effect for primary care if we're in secondary care, or vice versa. It might be societal costs, and increasingly we're covering things like environmental costs and societal benefits as costs that are being factored in and having a greater importance. Now, we never used to do that. We never used to really think about the benefit and to the environment and society. It's slowly starting to get better. I think this year is going to be particularly difficult, but other than that, we have been getting better. So fixed and variable costs are different in that fixed and variable costs are related to activity. Okay, so these aren't revenue and capital costs are based on whether they recur or whether they're one-off, whereas fixed and variable costs are to do with activity. So there are fixed costs, which are your overheads. Most staff salaries are actually fixed. All your admin support is generally fixed. It doesn't matter how much activity you've got, you've still got to pay the same amount, your baseline. Variable costs are consumables. The more you do, the more cost you have. Okay, so that's slightly different in terms of what they mean. Fine. So, any questions on value first? We'll come back to it in different contexts throughout the day, or the morning. Okay. Moving on to the structure. Okay. So this is the bit that's constantly changing. So the NHS in 1948 started. It was never a planned thing, in that it was never that we kind of went, well, we're going to have an NHS and we're going to make it so it's a coordinated and developed approach. No, what they did was just nationalised the existing, what was existing at the time. Okay, it ran out of money, year one. And since then, it's had multiple evolutions. In 1962, they tried that kind of to make it more planned. They tried to build a DGH for every 125,000 of the population. They started, and they ran out of money. They realised in 1974 they need some bit more of an overarching body. So they developed these health authorities. And then in 1990, they developed the internal market. So this is where organisations within the healthcare system would compete with each other to it's the full capitalist theory, where if you if people compete, then not only will they drive down costs, but they'll improve quality. The problem with that theory in healthcare in particular is that it works when in the boom times, when when the economies are booming, when things are in good, then that kind of system works. The problem is in lean times, when you're kind of in and out recession, or when economy's more austere, let's say, then you'll find that you get to this race to the bottom and quality drops because the costs have to drop. So that's why we keep kind of dipping in and out of the internal market over the last probably 30 years or so. In 2000, there was the NHS plan, and then the last really big reforms were in 2012, the Health and Social Care Act of 2012, where they put into legislation that competitive nature of things. They created CCGs, they created NHS England. They kind of, it was a really big restructuring. The problem was that between it being kind of devised, the idea being devised, which is when the Conservatives were in opposition, and it coming into law, 2012. The world changed. They had the financial crash of 2008, and then what is often happens in the NHS is that ideas are probably sound when they're first concocted, developed, but it's the implementation that's failed. And that's essentially what's happened with the 2012 reforms. The ideas of clinically led decision making at a local level was probably all right, and the idea was probably all right, but they created too many CCGs. They had 210 CCGs when it first started, and quite quickly they realised that they couldn't do anything in isolation. Everything had to be done in conjunction, and it was very expensive to do that way. So they ended up having to merge, and by the time they were abolished, we'd got from 210 to about 120, and there was a few others that were going to merge but didn't bother because they were going to get rid of them anyway. So we've kind of gone back to how it was before the CCGs came out, and a lot of the work in the 10 years between 2012 and 2022, when the Health and Care Act came into place, was to manoeuvre things within the legal framework to reduce the impact of competition, to reduce that competitive nature and try and collaborate more. And so when NHS England asked the government to make some changes to the legislation, all they really did at the time was to try and tidy up the legislation to make it fit with what they were already trying to do, which is encourage more collaboration, trying to close the gap between primary and secondary care. Is essentially what governments have been doing for about 20 years, is trying to reduce that gap. Okay, and we've all known that we have to try and shift some of the work out of hospitals because they are the most expensive place to deliver care. So that's basically what the Health and Care Act is essentially trying to do. Okay, so now if we go into the money side of things. So the budget for healthcare in England is set by the Chancellor, the Treasury Chancellor, and it's a negotiation. And so you get the spending review, which kind of sets out the plan for the next 3 to 5 years, and then it gets adjusted every year by the budget report. Okay. So the spending review this year is actually randomly in June. So it's in about a month's time is when they're going to kind of come up with a announcement for what the budgets for for health and social care will be for the next three years or so. Now, it's called the Department of Health and Social Care, but it does not fund social care. Social care is funded via the local authorities. And it only is only responsible for healthcare in England. So healthcare is a devolved entity, and so Scotland, Wales, Northern Ireland, they get to choose how much money they spend on healthcare based on their kind of grant allocation they get. Okay. But whenever the government gives the X amount extra into the NHS in England, often it will give an appropriate, pro rata amount to Scotland, Wales, and Northern Ireland if it's part of their grant, and then should they wish to, the governments then of those areas can spend it on healthcare. Okay. So, can we rank in order the budgets of the Department of Health and Social Care, the Department of Education, and the Ministry of Defence? Just 1, 2, 3. Who's got the most? Who's got the least? So most at the top, least at the bottom. Okay, so we've got a lot of people saying health, some people saying defence as the at the top, and then various people are changing. We've had all the connotations apart from education. We know that we don't spend enough on education. So okay. Fine. So it's not that much difference in terms of budgets for the current 25-26, but last year the budget for the Department of Health was nearly 200 billion pounds. Yeah, you'll get the slides and links to various things afterwards. So there's some animations which are on YouTube, and you'll get links to those. You'll get a recording, and you'll get the slides. Sorry, yeah. So health is 200, not just shy of 200 billion pounds. Okay, as I said, just for health, and just in England. Okay, education is about 90 billion pounds, and currently, so before the recent increases in defence spending, defence was just above 50 billion pounds. Okay. The question I'm sometimes asked is, how does things like the aircraft carriers and the kind of nuclear missile nuclear deterrent get funded? Well, they're funded over 20 or 30 years, so they are expensive, yes, but they're funded over like 20 years rather than an annual thing. So yes, you can say health is more is nearly 50% of all public sector spending. There we go. So if we look at spending as a percentage of day-to-day public spending, we're looking at just shy of half all money that the government spends on public sector spending is goes on healthcare. It also means it's very hard to get more money into the system. Until the economy gets bigger, we can't really ask for much more money, to be honest, because there isn't that much more. If we put more money into health, then we've got to cut money somewhere else, okay? And there isn't that much money around to cut. So the last budget in 2024, which is in autumn, there was a £22.6 billion increase in the revenue spending over the following 2 years, and they put an extra 10% increase into capital budgets. Okay, your big one-off budgets, and so they put some money into surgical hubs, diagnostics. They put some money into cybersecurity, and hundreds of millions of pounds into upgrading GP surgeries. Okay. So this shows how that money then is spent. Okay, so you've got the blue bit is, so the whole thing is the Department of Health and Social Care's budget, the whole bar. The first bit is what the Department of Health and Social Care have to fund their own internal mechanisms, and we'll come to that in a second. So most of the money goes to NHS England, okay, and as part of their revenue budget, so their day-to-day spending budget. And then there's a small amount, the grey bit at the end, which is their capital budget. Okay, and that's for your, building new hospitals, purchasing new things, all that kind of stuff. Historically, what's happened is, and where some of the problems have been, is that despite us having such a big orange component, so revenue, NHS England revenue budget, we've overspent. It's cost us more to deliver those kind of case, the care that we wanted to give, than we've had in our budgets. So we've had to take money out of the capital budget, the grey bit, to plug the gap in the orange bit. But that's counterintuitive almost, because it means that we can't develop the new hospitals, the new systems that we want that will actually help reduce those costs in the future. So I'm in Leicester. We are a 3-site hospital. We want a new ITU, we want a new maternity unit. We do that, we will cut our costs massively. Just because we would then merge some of our ITUs, we'd merge our 2 separate maternity units, and we'd get economies of scale because we wouldn't have to have so many tiers of people in every area. Okay. But we're not going to get that money for another 10 years. So we're going to be, trying to maintain these systems for 10 years. That are not going to be cost effective, really. But that's because we haven't got the capital budget to make those things to happen. Okay. So that blue bit at the beginning seems like a lot of money for just the Department of Health and Social Care. But the Department of Health and Social Care has to fund from that 11 organisations. Okay. There it's arm's length bodies to varying degrees under it. Okay. NHS England is one of them. Now, you might have heard the news that they're going to be abolishing NHS England. A lot of the work that NHS England is doing is going to basically go into the Department of Health and Social Care, and some of the work is then going to be delegated back down to the ICBs, okay, of which there are going to be fewer. But I'll come on to that in a second. But there are other organisations that are funded directly by Department of Health and Social Care. So how many can we name? I'll come to that. How many can we name? So NHS England is 1. How many others? Yep. Yeah, we've got 2. That's not bad. We'll go through them in a second, but so Public Health England doesn't exist anymore. It's called the Health Security Agency, which is the UK HSA. HEE doesn't exist anymore. So GE services come out of the local authority money. It's part of, it's kind of indirectly public health, but local authority. Well, I'll come across that in a minute. Any more? You'll have heard of some of them at least. No, we fund the Victoria MC and Royal Colleges. So ICBs and primary care networks come out of NHS England's money. So you have NHS England, then you have the ICBs and primary care networks. All we're going to do is just remove the NHS England kind of component out of it, and so it'll go Department of Health and Social Care, ICBs, primary care networks. So NIHR does, but it's not a strictly speaking an arm's length body. It gets some money from it. Nice, yes. Not volunteer services. They are charities. They might get some grants for providing certain services, but they're not kind of funded. They're not deemed an arm's length body. So they've been categorised based on what their categories are. So it often depends on how much control the Department of Health and Social Care has. So executive agencies are under direct control of Department of Health and Social Care. You've got your MHRA. So they are you'll know of their the American equivalent, which is the FDA, but the MHRA approves vaccines, approves all kind of kit, approves all drugs and medicines essentially. And then the UK's Health Security Agency, which was formerly known as Public Health England until during the pandemic it got changed. Now, bizarrely, so money comes from Department of Health and Social Care. It goes to the UK Health Security Agency, but the public health component of it then is then given by the Public Security Agency to local authorities. So your local public health director sits in the councils, in the local authorities, rather than within the NHS. Okay, and then the councils then pay back into the NHS for screening programs, vaccines, for public health type things, services. Okay, so it's this kind of bizarre kind of it goes out and then comes back into the NHS. Both of those have UK-wide remits. Increasingly, a lot of them have UK-wide remits. So as does NHS Blood and Transplant, which is responsible for donors, organ donation, blood transfusions, all that kind of stuff, transplant services. The Business Services Authority, which is responsible for pensions and prescriptions and other kind of business-related stuff. NHS Resolution is the not so new name for the Litigation Authority. So they manage the kind of indemnity insurance for the NHS. And then you've got the Counter Fraud Authority, which is a small body that sits within there. And then these are more at arm's length. So the commissioners, NHS England, currently, as I said, they're going to be got rid of, and we think that it's going to go to the Department of Health and Social Care and the ICB, so the roles are just going to be split between the two of them. But then you've got NICE, National Institute of Health and Care Excellence. Health Education England and NHS Digital existed until a couple of years ago, but they were brought into NHS England and then subsequently will be brought into the Department of Health and Social Care. The two reasons for that. One is to allow more joined up thinking, so you can have a combined workforce strategy and a combined IT digital strategy, rather than kind of different groups doing the same thing. The other reason is that whenever governments of any kind of type say they're going to protect the NHS budget, they only ever mean the budget of NHS England. And what's happened historically is that other organisations like Health Education England, NHS Digital, then have to cut the costs because the Department of Health and Social Care costs get reduced. So you get this kind of weird dynamic where the budget is protected, but actually the overall budget of all the other agencies is cut to maintain that. And then you've got a lot of your regulations. So you've got CQC, you've got your kind of more niche ones, so Human Fertilisation and Embryology Authority, the Human Tissue Authority, the Health Research Authority, and then the relatively new one, which is the Health Services Safety Investigations Body, which is like the airline investigations body. Okay, the No Blame, looking at themes body. Okay, I'm just going to go back a couple of slides. So this is an interesting slide from the King's Fund. Okay, so we need an NHS an average increase of between 3 and 4%, really, to kind of maintain and slowly start improving our services. We have, since 1948, on average, had 3.6%. What you will find is that it's been very up and down. So we did get quite a lot of extra money during the pandemic. I don't think a lot of the money was spent wisely, but we did get a lot of money in that time, which then slightly dirties and muddies the figures a little bit. But for many years we were on 1 to 2%, and so we are suffering the consequences of that. I don't think we are going to get anywhere near the 5, 6, 7% that you can do, and certainly not the 5, 6%. We'd be lucky to get 3 and 4% this year, because of the way that the finances are and the world economy is at the moment. But we'll see. So in about a month's time, we'll get an idea of what our increases are for the next year. Okay. So NHS England gives some money to directly to providers for specialised service, and we'll come to that in a second. But most of the money goes through the integrated care systems. Okay. Now, this animation will hopefully simplify it a little bit. And it repeats some of what I say, but hopefully we'll just cover it, and you can then watch back later.
We've got passion, we've got determination. And if we set our sights on something, you better believe it's happening.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years, to create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have 4 main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
So, just to kind of clarify a couple of things on there. System control total, collective performance targets are all related to the issue that sometimes you get with organisations within one area is that the acute sector, anywhere where the A&E tends to lose a bit of money because of the type of contracts are on. And historically, what would tend to happen is that some of the other organisations, so whether it's an elective centre or whether it's a community and mental health partnerships, would either break even or make money, and there was basic disincentive to kind of shift stuff from hospitals into the community because they were all competing with each other, and there's no mechanism to do that. So what this control total means is that it encourages organisations and local authorities to work together to make sure that they spend money in the most appropriate way. So that's the idea behind it. I don't think it's quite come to the level of fruition as intended yet. So to give you a bit of background again, and to go over just the integrated care systems, because they're probably the most complicated of the new developments. The integrated boards have all the representatives of of care providers in the area. Whereas the Intercare, and they are the statutory body, they are the main body that determines how money is spent. The Integrated Health and Care Partnership is more a more advisory area to kind of look at the kind of the gap between health and social care, and that's why they've got the third sector, the charities, and some of the independents and people, things like police and other people that may have an interest in that kind of health and social care area. Health and Care Act was kind of formally done in 2022, but as I said, it was based on suggestions suggestions by the NHS England back in 2019. The main things are the ICBs and ICPs, but also it got rid of that duty to compete. So before the 22 Health and Care Act, whenever an ICB or CCG or whatever it was, and a commissioner wanted to commission a service, they had to put it out for tender. And that's not only time consuming, expensive, it then opens it up for the potential where private enterprises can come in but may not deliver what they were intending to deliver. So a couple of times over the last 10, 15 years, we've had private entities come in, win a contract, and then within a few years give back the contract because they can't make it work. Most famously was Circle, who took over an acute hospital in the Midlands, essentially between Leicester and Cambridge, and then ends up giving it back because they couldn't. It just wasn't profit. They couldn't make it profitable or as they planned. It's not to say that some services haven't done okay as part of that competition, but it's mostly services that are difficult to do by the existing organisations, and it tends to be the ones where it was third sector, so charities or community interest groups that have taken over things like drugs and alcohol services and various other things like that, which are small in scale, and there's the people who've got a vested interest in them. So they've tended to work. A lot of the other ones that haven't done. So the other big thing that's happened is that kind of simplifying of the terminology. So this changes, you had NHS England, you had NHS Improvement, which in turn was already two different bodies officially. And what they decided was that, so historically, you had back in the late 90s, early 2000s, maybe even later than that, there was a drive to give organisations, particularly secondary care hospitals, more independence, to make them more at arm's length from the government, and that's what foundation trusts were meant to be. They are actually semi-independent. So they have, if you work in a foundation trust, you may know that you have your board of directors, but you have a council of governors above it, because currently, anyway, you're not directly responsible to Department of Health and Social Care. You're almost a semi-private entity. They had this idea that they were going to make people into all organisations to foundation trusts, and you had Monitor, who was the kind of organisation that was then there to regulate it, to look after them, and then you had the Trust Development Authority, which was then to try and help those other organisations to become foundation trusts. And then what you found was that quite quickly they realised that wasn't a great thing. Giving people these independence doesn't actually work and doesn't actually improve things to the degree they wanted to. And so they stopped that, and slowly over the last 10 years or 15 years have been trying to reel them back in, essentially, to get a bit more control over them again. But they merged the Monitor and the Trust Development Authority into the NHS Improvement. So they were the regulator from a finance and kind of sustainability point of view, as in financial sustainability point of view, and then NHS England was the commissioner and ultimate regulator from a kind of safety and kind of commissioning point of view. And then they did that for a couple of years, well, five years or so, and then they realised that actually you then had NHS England saying you've got to deliver safe staffing, and NHS Improvement saying you can't afford to deliver safe staffing. And all the organisations were in the middle going, I don't know who to listen to. And so they realised that they had to then give a single message. So they merged, were briefly called NHS England and Improvement for a while. And then when everything went through, now there's just one body that's looking after the NHS England, which is NHS England. And actually all that tidying up has done is made the government realise that there's already too many bodies. If you've got one body called NHS England, but the Department of Health and Social Care is only responsible for the NHS in England, it seems silly to have two bodies. The other thing that's kind of led to this is that those changes that were made have actually increased the power to the Secretary of Health, State for Social Care, Health and Social Care. So Wes Streeting is actually more powerful than Jeremy Hunt was before the pandemic. Okay, in terms of his responsibilities and the control he has over the department of NHS England. Okay, I mean that might be a good time to have a quick 10-minute break. Any questions on the structure? And we'll do payment systems and costing and clicks, and then we'll have another break and then go into the business cases at the end. So 10 minutes now. Is that all right? I'll come back at 22. I'll be back a bit earlier if you have any questions. Cool.
It seems taking too long this time. What's that? What was it? A day or so? Yeah, not too bad.
Loud in a session.
Yeah, absolutely. It can.
Right, any questions before we go on to payment systems of the NHS? Okay. As I said, feel free to put them in the chat if you think, as and when you think of them. So we talked about the kind of the national structure, so how we get paid, or how the budgets get determined in the NHS. But how do our individual organisations get paid? Okay, and this is constantly changing. There are some principles, but the exact mechanism changes year on year. The NHS payment system is tweaked every year, and one of the problems that we have here is that often the payment system for the following year doesn't get confirmed until, well, it hasn't. I don't think it's been fully confirmed yet, and we're about 6 weeks into the new financial year. So budgets are still being kind of planned, and everything's been a bit delayed this year. It has been for the last couple of years, in fact. So what I'm going to try and do is give you the building blocks. So there are 7 ways in which you can have a service paid for in the NHS, and we'll talk about different aspects of it, and then we'll go down to the current system for acute and general practice. Okay. So the first type of paying for systems is something called block contract. Okay, a block contract is a fixed amount, a lump sum payment to cover a range of services. Okay, and once you kind of, when you're doing your negotiation for how much that thing is worth, then you kind of work out what your expected numbers are, but it doesn't actually matter what you actually deliver, whether you deliver more or less. Okay. The benefit is that it's predictable. Okay, you know how much you're going to get paid, and the commissioners know how much they're paying out. Okay. So the main benefit for this is it's predictable. Okay. It is ideal for times where either things are uncertain or it's difficult to measure activity. And that's where we tend to use it. So during pandemic, we used it across everything. For things like community services, which are quite difficult to measure activity, it's been used. It has been used even pre-COVID for the acute sector, when there was so much concern about trusts overspending. They, in some areas, they went for this kind of block contract where they kind of went, right, just to make sure that we can actually deliver the same amount of care, and make sure for our predictability purposes, we're going to give you a block contract. Okay. The downside is it means there's no incentive. So, for example, for the organisation, for the provider, if we say we're going to do 100, it doesn't matter if I do 100, if I do 90, if I do 80, we won't get penalised. It's a fixed amount, and there's certainly no way I'm going to do 110, 120 of whatever measure whatever service you're providing, okay, or 100% of it, because it doesn't actually matter on the demand or what's delivered. If I were to deliver 120%, then great, the commissioners get good value for money. If I only deliver 80%, then the commissioners get bad value for money, and the opposite is true for the providers. Okay, so that's why it's used in extremis, but it's not generally a great way of doing it. The capitation is a lump sum payment related to the size and complexity of a population. Okay, so it is, you have your population that you cover, and then it's adjusted, and it's that adjustment factor that's the key difference between the different ways the capitation works. So capitation models are used in determining how much money the ICBs get. It's how much money the health boards get in different parts of the world, so including Scotland, Wales, and Northern Ireland. A lot of that is a capitation model, and it's also the bulk of the standard contract, so that the general medical services contract that GPs get is covered by the capitation. Okay, and what they tend to do is factor in things like socioeconomics, age, accessibility, rurality. All of that is factored in and weighted to different proportions, and that's then given out. So you get a weighted population, and there's a per person payment to the organisation that's being capitated. Okay, so per head. The pathway of care is gone out of fashion at the moment, but it comes in and out, and a lot of these things they can come in and out of fashion over periods of time. Pathway of care, when there was one pathway for a whole pathway for a certain service. So maternity was historically the one that was used that we used this for. We had pathway of care. You had one payment for antenatal, one payment for intrapartum, and one payment for postnatal. And at antenatal, you had 3 levels. You had low risk, medium risk, high risk. At intrapartum, so birth, you had 5 levels, and there were 3 at postnatal as well. And what you then found was that you had a lead provider who could then outsource different parts of the pathway. Okay, and it has benefits because of that ability to outsource different parts of the pathway, and it's a whole pathway model. So you're looking at a whole pathway thing, which is good in many ways. The problem was it wasn't very flexible, and maternity services were probably the worst scenario that you put it into, because what happened was if at booking you were low risk, then you got paid the low risk tariff amount. It didn't matter if you then suddenly became high risk midway through your pregnancy and needed lots more scans, lot more interventions. You still didn't get any more money until you got to the intrapartum bit, in which case you'd be bumped up. Okay, so it didn't really work very well because it was very inflexible. So that's why it's gone out of fashion for a bit. Pay performance is generally in some way or form in every contract. So it's a big part of the GP contract, which is the QOF, the Quality for Outcomes framework. It can contribute up to 20% of your income if you're in general practice. Historically, we've in the acute and community mental health sectors, we had the commissioning for quality and innovation sequins, which at one point were worth 2.5% of your contract, which is quite a lot. And then it went down to 1.25%, and now it's non-mandatory. So you can sign up for them if you wish, but you don't have to. So it's kind of gone out of favour. The main reason for the sequins going out of favour was that they change every year, and what you ended up with was you ended up having ongoing costs for delivering last year's sequin, but we weren't getting paid any more for it. Okay, and the other thing was that you kind of almost factored in the sequin achievement into your budgets, and so if you didn't achieve it, then it was like a massive loss. It's almost like a penalty rather than a kind of extra bit. And so they've kind of gone out of fashion. There are other ways of doing it now, which are best value tariffs, which we'll come to it when we do the case-based. Per diem is not really used in this country very much. It's a lump sum payment per patient per day of care. So you can have level 0, level 1, level 2 kind of care or wards, and you get different tariffs for those. Used a lot in other parts of Europe and some other parts of the world. Case-based is probably what is increasingly used, particularly in elective care. It's activity-based. The more activity you do, the more you get paid. Okay, it was the main payment system for many years in the acute sector. It was tried in the mental health services sector. It's kind of worked to a different degree with that. So in the acute sector, you had 3 components. You had your diagnoses, you had any treatments you got delivered, so operations, and then you got your patient characteristics, which are your comorbidities. And then they got put into a computer software program, and you came up with something called an HRG, Healthcare Resource Group. And the Healthcare Resource Group is basically what the tariff is based on. So it's just a code which equates to something, which groups things that cost about a similar kind of amount to deliver in one go in per HRG, and then there's a cost associated with that, and that was your income. It's now still there, but it's less dominant than it used to be. In mental health services, it was all based on clustering, rather than it being the kind of HRG thing. But the problem with that is often what was happening is in cold or elective work, it worked fine. But in the acute emergency pathways, it didn't work because it would always cost you more to deliver those services than in the acute sector, in the emergency pathway, than it did in an elective pathway, and it didn't really factor that in well enough. The tariff is determined by taking an average of all the organisations that deliver a service have to send in how much it costs to deliver that service. So how much does it cost us to deliver an appendix, for example, or a hip replacement, or a chest infection care, pneumonia, inpatient pneumonia, and you do that. You send in how much it would cost you to deliver that. And the problem was that for years the data has not been very strong. We've not known how much it's cost us to deliver that, and we've kind of gone finger in the air, made a guess, and that's meant that those averages are not very accurate. And what they do is then you take that spectrum, you take the average, you adjust it for inflation, you put a efficiency factor in, and then that becomes a tariff. And because elective work is easier to kind of work out how much it costs you to deliver, you tend to get accurate payment system, accurate price for it. The acute system is always so varied, and so the emergency pathway is so varied and so different, and it's really hard to pinpoint how to measure those costs. It has not really worked. What they have done also in the case-based system is, or the activity-based system, is also put these things called best value tariffs, which are you get one price if you do the operation or do this pathway or whatever it is, but you get a higher price, you get more money if you achieve certain criteria, so you get a higher reimbursement rate. So it's a pay performance by a different way. And the final way is pass-through payments, where the cost of service delivery is paid by the commissioning body. Example is some of the really niche specialised services, and then things like high-cost chemotherapy drugs. So whatever it costs you to deliver that, it gets repaid, reimbursed by the commissioners. So that's the 7 different ways you can pay for this stuff. Okay. So for the last couple of years, and in some generally for next year, you've got this thing where you've got it's called the aligned payment incentive model. Okay, and essentially it's a mixture of a block payment and then a case-based payment. Essentially what it is. Okay, so you've got your block payment, your fixed element for your acute work. Okay, so acute activity, maternity, ambulance service, all the things that are difficult to measure, and yeah, all that kind of stuff is done by your fixed element. Okay, and includes your best practice tariffs, your expected best practice tariffs, and expected sequence if there are any. Okay. The CNST is that indemnity clinical negligence scheme for trust. It's your indemnity scheme. Okay, and so all that should cover your basic overheads. So that's your basic stuff. And then you have the low volume activity contract, which is then you have your variable element, which is your elective work. So that's to drive down waiting lists. And so the more you do, the more money you get. Okay. So that's why you've got the combination of the two. And that's the majority of contracts. So if you are a commissioner and commissioning into a local region or into a neighbouring region, you'll probably go on that kind of system. Okay. The low volume activity contracts are basically for areas where you don't tend to get people. So, in Leicester, we don't tend to get many people from Cornwall coming up and visiting us. Okay, so we will with the kind of the Cornwall and Devon ICBs, we probably wouldn't have a major contract with. We might get the occasional tourist or family member that comes up and gets treated in our hospitals. Okay, what you'll probably find is that, and so we would have a low volume activity contract for those to reimburse us for those kind of patients. And you might get the same kind of thing in other parts of the country. We get, we probably have a normal contract with Lincolnshire because we get patients coming from Lincolnshire, and Boston would probably have patients coming from Leicester in the summer. So you have those kind of relationships. But anything where it's uncommon for people to go, then you'd have this low volume activity contract. General practice, there are now two main types of contracts. Okay, there's something called the General Medical Services Contract, which is what historically what was given to most people, most GP practices, and it was given to the GP. So you as a GP were given the contract, okay, and the funding for X amount of patients. And it was comprised of basically your bulk was the capitated model, and you got which is about 40 to 45% of your income was based on that. You had 20% to 25% based on your QOFs, your quality outcomes framework, so ticking each box. And then you got extra other bits for things like your property services, or if you had a pharmacy on site, or if you need salary GPs because of your or pension costs or sickness costs or maternity benefits and stuff like that. They were then incorporated in as extra bits. But increasingly, what you're finding is that primary care is being given to established companies. So whether it's collaborations of GPs or whether it's a kind of a private company, Virgin Health, whatever it is, that are going to run GP services, then they're called what is alternative medical provider medical services, okay, contract, so APMS contract, and they are similar kind of capitated kind of contract, but they're fixed term. So GMS contracts are actually for life in theory. APMS contracts given to organisations are for fixed terms. Now, historically, when they first came out, they were for like 5 years, but increasingly they can like to 10 to 15-year contracts. Okay, so you can actually run your services that way. What you're also finding now is that some NHS organisations, so in Wolverhampton, for example, they run the Wolverhampton acute sector, the acute hospital, runs a load of primary care practices, so GP trusts, GP practices. And on the south coast, there are GP practices are owned by the Community and Mental Health Care Partnership, or the Community Partnership. Okay, so increasingly you're finding there's different ways of managing primary care to varying levels of success. Okay, so generally primary care is private. So whilst they're commissioned by the NHS, they are private entities in themselves. And they get access to the NHS pension and stuff, but they don't have to. They're not obliged to use it. So it does work slightly differently, and they are businesses within themselves. The primary care networks, increasingly, what they're trying to bring more and more primary care within to the NHS kind of banner a bit more, and I think that's probably what you'll find increasingly as. Being a GP partner in much of the country is less appealing to a lot of people who are doing GP, then you'll probably find that they're going to be taking part in either the big companies or in NHS practices run by another NHS organisation. That's probably what's going to happen. Okay, any questions on the payment systems? No? Okay. Yes, Matthew.
I'm gynecology. I just wanted to ask, when you have outside companies coming to do waiting initiative lists and who are not necessarily from the hospital, where does that budget come from?
So often it depends on. So it depends on. So if it's insourced.
No, it's outsourced.
So when you say outsourced, so there's two different. So when we're talking about private companies, so for example, in my hospital at weekends we get another company comes, provides their own staff, but uses our theatres to deliver waiting list initiatives. So it's not our staff, but it's our theatres.
Okay.
So is that what you mean, or is it? That's called insourcing, and that's where.
Okay, sorry.
So that's called insourcing, where you use the NHS facilities, but somebody else comes and staffs it, and that, in which case, that's because we can't staff it. Therefore, we've asked somebody else to deliver it. So that's come out of our budget. So that's from my organisation's budget. Okay. There are some things where it's outsourced. So, for example, the ICB has outsourced local cataract operations to another company. So all the cataracts that can be done under topical get done somewhere else that nothing to do with us. And a lot of all the hernias that, if a GP refers a hernia, inguinal hernia or femoral hernia, they get screened by a private company, and then if they can be done to the local, they'll do them themselves, and if not, they get funneled back into the NHS. So that's outsourced, and that's funded by the ICB. So it depends on what you're talking about. So there's some stuff that's insourced, then that's using our facilities, and that's because we can't deliver the staffing of it. So we've got the theatres, we've got the staff. They use our facilities and our post-op wards, but they often provide the surgeon and theatre staff. That's provided. I mean that the cost of that is borne by us as the acute hospital. Outsource is often a pathway change, which is done by the ICB.
That's really helpful to know. I just wanted to know that differentiation. Thanks. That's really helpful.
No problem.
Yeah.
All right. So that's insourcing, outsourcing. GP contracts, the APMS contracts. They don't have a fixed process. They don't have a fixed. The payment system doesn't really apply to them in the same way as the old GMS contracts, which are much more. There's a contract. There's didactic. APMS contracts are a contract between the commissioners and the company. Okay, they are fixed term, and they are often they're based on capitation models essentially and QOF payments, but they don't have that level of detail in them, and they're two companies, so they are given to the company rather than to the GP. Does that make sense? And then social enterprises are they're like community interest groups. They are not-for-profit organisations that have set themselves up and then can bid for to deliver services. So often in some areas you get social enterprises can do things like drugs and alcohol, or early pregnancy units where they do kind of public health contraception kind of care and things like that, family planning type stuff, often run by social enterprises, where they can bid for contracts essentially, and it's often where they're small services, cover a specific region. So you might get one for one area, another one for another area. They don't tend to be big, massive profit-making enterprises. They are very much for community benefit. So there are people that have set them up as not-for-profit to deliver a service. They take a salary, the people are employed, so they get some money, but they're not. Their main aim is not to make a profit. Does it run? The company can run multiple GPs. They can run multiple GP practices, or they can run they can employ multiple GPs within their hospital, within their practice. So you can have, there are several that run 20, 30 practices across the country. So the company can get contracts from different ICBs essentially, and then they might have 30 contracts with different areas to supply the services for GP services. What you had, so historically, one of the problems, so I'm not sure if anybody's heard of Babylon Health. Babylon Health was was very much a disruptor in the kind of primary care market. So they were offering the kind of online. They were an online only GP service, and they targeted big urban areas generally, and would take on. They offer these kind of online GP services. Okay. The problem with it was that when you have your capitation model, you have high users and low users. Okay, high users tend to be elderly, multiple comorbid patients. You get a little bit more money for them, but you have your kind of young patients who are on your books, but you very rarely see, or you might see for 5-10 minutes every few weeks, every few months maybe, and some you'll never see. Okay, and often what happened was that the fact the money you got for the kind of young people didn't use the service offset the money you had to end up paying to deliver all these older patients care, high users. And when a group like Babylon Health came, you ended up registering with them, and they couldn't take you if you had lots of comorbidities because they couldn't manage it. And so by definition, you ended up with all the young patients going to them, mainly because they offered, out of hours work. They offered lots of flexibility, easy to get appointments, stuff like that. And they wouldn't take kids and all that kind of stuff. So they then took out all the buffer from a lot of the other GP practices in that area, which is why they kind of struggled. And then when the commissioners said you can't be so selective, they kind of it didn't work as a finance model, because then they wouldn't get the money. So that's why they kind of came into existence and then were bought by another company, and then and now a part of the GP services that places offer, but are not a key a GP service in themselves generally. So who pays for theatres list reduction issues? We can list by hospital staff and there's Dunsley. So waiting lists, they're paid for by if you're doing it within the hospital, then it's the hospital pays for it. So yeah, so there were extra funds. So about 3 years ago, there was a big push to try and get waiting list initiatives done, and there was an extra recovery fund, the provider recovery fund. So they had a PRF funding, which is what it was called, and so the extra set a little bit of money set aside to do these extra bits of work to drive down waiting lists. That's slowly been tapered off, and so now it's within your baseline. But that's why there was a period where there was a lot of that stuff happening, because it came through a different funding stream. But it is still paid for by the hospital, but they could claim more money off the government essentially because of that. I think that's all the questions answered, hopefully. Right, we're going to go into costing and coding. So my first question is, what's the difference between cost and price? It seems quite basic, but it's really fundamental to understanding, particularly the financial environment in the future in healthcare. Difference between cost and price. Okay. Yeah. Yeah. Okay. You're both right, but I'm gonna keep it even, just very basic. Okay. You're closer. Yeah. So that's probably more what I was trying to get at, is that the cost is the amount spent by a provider to perform an activity, i.e. the expenditure, and the price is how much you're going to get for it. Okay, how much you get reimbursed for it. Now, whichever type of contract you're on, that's basically what you do. Okay, and historically, most organisations, okay, were only really concerned about the price. They were generating income. The more income they get, the better. And that was a driver for business cases, for all types of quality improvement projects, service improvement projects. It was all about whether you can drive income. Okay. Now, over the last probably 5 years, we've flipped. Okay. And the price we're getting is going to be fixed. Even if you did 100 different good things, it's unlikely to be able to generate more money, because even if you did stuff that could generate more money, it's unlikely to generate more money because there is no money to kind of to give out. It's not like the commissioners are sitting on money for them to kind of give out if you do more. Okay, so there is very little more extra money that's around. So the main driver for everything else is reducing the cost. Reducing the cost of your pathway is what is the key to everything. Okay. So whether you stay, whether you do more as day case, whether you see fewer follow-ups, see fewer patients more patients in your clinic, try and do more stuff digitally, do stuff more locally. Yes and no, but you still want to maintain quality. Yes, that has been probably one of the drivers of enhancing some of the non-medical roles, because they are cheaper. Whether they still give you the same cost benefit is not as clear. And my argument is, and the argument I make as head of service is that the cost benefit's not there. So we in my department, so I run the anaesthetic department at the Royal. We don't have AAs or PAs or PAAs, whatever they're called, because the complex nature of the work we do means that there is no benefit for them. The cost benefit doesn't work. I'd rather have consultants because they can do more and are more flexible. So in some areas, to be honest, it's kind of it's not really there's not really debate anymore about that in my areas anyway. However, there is that focus, but we have to look at pathways, and I think that there's been too much focus, and a lot of the problems that we have in the NHS is focusing on individual bits and not on whole pathways. And the areas where they've done a lot of good work and have reduced the pathway costs are where they've gone into the data and looked at coding, looked at other things like that, to kind of look at, it's not about whether you deliver that service or not, it's how you best deliver that service. Okay. And what the easiest way to do it is, and is looking at the whole pathway. But the thing that drives it all, and the thing that allows you to be able to do that, is clinical coding. Whether it's clustering in mental health, whether it's your coding that you do in general practice, or clinical coding in the acute sector, coding will drive all of this data and cost analysis. So I'm going to show you a little video on animation on what clinical coding is, why it's so important, and then we'll come back and normally this generates a few questions.
I took two things that I love, dancing and dogs, and I made them into a successful business.
This animation will give an overview of clinical coding in the NHS. Essentially, clinical coding is the way an NHS organisation records information on what care is given to their patients. It is the translation of the patient record into coded data. It is usually done after the patient has been discharged, and there are strict deadlines that need to be adhered to for data submission. So how does clinical coding work? A patient's hospital stay, from the point of admission to discharge, is called a spell. During their stay, a patient may be under the care of different consultants. This may be due to a change in shift, ward, or speciality. The time period under each consultant is called a finished consultant episode, FCE, or episode of care. So a spell can be made up of a single or multiple FCEs. Clinical coders code diagnoses, comorbidities, complications, and any procedures undertaken for each FCE. So how do we get from treatment to coded episode? All care delivered during a patient episode is documented in the patient notes. Once the episode is complete, the notes are sent to clinical coding, where trained clinical coders carefully read through the notes and allocate the appropriate alphanumeric codes. For diagnoses, they use the International Classification of Diseases 10th edition, ICD-10, which comprises over 16,000 codes. And for procedures and operations, the OPCS Classification of Interventions and Procedures version 4.9, which has over 4,000 codes for procedures and operations. The codes are entered in computer software which determines the Healthcare Resource Group, HRG. Most, but not all HRGs have an associated tariff. An example of this: clinical coders are like detectives, investigating all aspects of their journey from start to finish. You begin by reviewing the documentation, physical and/or digital, for the stay. For example, an elderly woman who had a hip operation 2 days ago. From her medical notes, you find out the main condition being treated, any relevant comorbidities, and the procedure performed. Then, utilising the ICD-10 and OPCS procedure classifications, you find and assign the special alphanumeric codes and record these into the organisation's patient administration system. This coded data can be understood throughout the NHS and beyond, and used to plan for future patient care. What are healthcare resource groups, or HRGs? A healthcare resource group, HRG, is a grouping of diagnoses and/or procedures which are similar in terms of care delivered and the resource used. In order to reflect the complexity of care delivered, HRGs capture main condition treated, investigated, procedures, investigations performed, comorbidities, complications, age, length of stay. Healthcare resource groups offer organisations the ability to understand their activity in terms of the type of patients they care for and the treatments they undertake. Why is clinical coding so important? Clinical coding provides the information that underpins almost all the data flows within the hospital. It can be used for clinical governance, quality improvement, epidemiology, benchmarking, commissioning, financial flows. The challenge: coders are only able to use information that has been documented in the clinical notes. Incomplete or unclear documentation has been repeatedly shown as a weak link in the data quality chain. Now we know how important accurate clinical coding is to NHS organisations. Here are some top coding tips. Clear. Write clearly and legibly, type if possible. Use appropriate language. Check with your organisation, as some have agreements to accept certain terms. Complete. Ensure all diagnoses and procedures are recorded in detail. Document all relevant comorbidities. Understandable. Abbreviations and shorthand cannot be coded. Coders are not allowed to interpret investigations or numbers. Accessible. Make sure the coding team know where key information is recorded.
Okay. Any questions on coding? Okay, so yes, so we will get to a point where the role of the clinical coders will be more as checkers, so that they kind of do auditing the quality of the coding rather than necessarily doing the coding themselves. The problem you have at the moment is that a lot of the EPRs, the electronic patient records that we have, it's to do with how the fields are kind of coded or how they're listed and how they can be brought across. Increasingly, what you'll find is that with the electronic patient records, we'll be asked to document more in SNOMED terminology, which is a certain type of terminology which is closer to how we would describe stuff, okay, rather than how the ICD-10 or the OPCS code stuff. So in mental health, they use the ICD-10 much more, ICD-11 now, much more than we do in the rest of medicine. But how we describe stuff in our clinical terminology, SNOMED is currently the kind of the main record of doing that, and that's what's being adopted across the NHS. That then will link, so they don't quite match completely, but increasingly they will be matched across to coding, to the ICD-10 OPCS4 codes. And that'll be a much better way of doing it. But at the moment, if you've got free text boxes, they are very difficult to code. And in the same way as they are not allowed to interpret abbreviations. And so when we type stuff as an abbreviations, or when we write stuff in documentation as abbreviations, it doesn't happen. It doesn't go very well. Yes, exactly. So there are lots of things that mean that we probably don't get money. I mean, the money has always been the driver behind all this, but the big issue is that it's your mortality statistics, your benchmark statistics are all driven by the coding. Okay, so for me, yes, we can generate more income potentially if there's any more income out there. But what I want to demonstrate is that my quality of care is actually not as bad as the coding suggests it is. So, there are been lots of studies. So Leeds have been very good at this. So they've done a lot of work where they've analysed the different areas. Both Nottingham and Leeds have done this, where they've analysed different areas. So, for example, they investigated the cath lab. Okay, they saw that most of their standard angiographies were taking 45 minutes, but there was a whole group of them that were classified as angiography standard, but were taking an hour and a half. Okay, and when they looked into that, they found that actually most 90% of those ones that were taking an hour and a half were actually not standard angiography, but more complicated, and so should actually have been upcoded, but they weren't documented as clearly as that. And what they found is that then brought down their all their benchmarking for things like expected length of stays, for complication risks, for mortality. All of that was changed, and then you could then make a business case to get more a bigger angiography suite, because actually they were doing more complicated stuff. Okay, and the results were better. So you can use things like costing, which we're going to come into in a second, to look for problems in coding or look for problems in your pathway. Yeah, so it's the coding you do in GP is less. The detail is not as detailed as what they need to do for hospital stuff, essentially. So the coding in A&E and in GP practice are mostly done by the clinicians. Okay, but for most of them, they're short encounters. They're not for 3-4 day encounters, and so the level of coding you need is different. I did one of my previous roles. I was a lead for coding, and we did just a thing where we got a clinician and a coder to summarize the key points out of a set of notes. And for us as clinicians, the detail that we use and we think is important is not necessarily the detail that the coders think is important, or for coding is important. Okay, and that's where the difference is. Yes, it will be a massive role for AI. The major problem at the moment is all about exporting patient data. Okay, because most of the developing AI are not UK based and are certainly not approved to work with that amount of data, of potential personal data. And so it's getting access to the data in a anonymized form, and how we use that to train the machine learning. So machine learning has got a massive role. It's how because this is all personal, potentially patient identifiable data, and how do we train AI to be able to do that while maintaining security? And that's going to be the difficulty. And that has been the difficulty that we tried to face for the last few years. It will probably become easier, and at some point we're going to have to compromise a little bit. But that's where the issue is. It's not that people are against it. It's the bureaucracy and the privacy side of things makes it very difficult. Okay, so I'm going to move on to costing. So this is how we determine how much it costs to deliver a service. Okay, and as I said, historically we've kind of done it in a kind of finger in the air guesstimate type things. And patient level information costing systems, which is what Plix is what's going to probably give you a much more developed idea of how this works. Okay, this is going to focus on the acute sector, but the same kind of things applies in mental health and in general practice to a degree. They are planning on building the cloud centers. They just need the money. So they are having secure data sites, regional areas built. It's just taking a bit of time. So from discharge, they've got 3 to 4 weeks. Between 3 to 4 weeks for tight deadlines, which when you're going through notes that are potentially this big, or the episodes that can be 4 or 5 kind of days of episodes, and depending on how many, so you've got, that's your spell, can be 5 or 6 days, but you could have multiple consultant episodes in that time, and that can then, coding each one can take some time. Okay. Plix. So patient level costing is the future. That's going to help how we can work out how to best deliver our services. So patient level costing, and this is clearly not my slides, these are from Manchester University and a great costing team there. So what they do is you divide up your resources and down to patient level. And you then allocate your resources to an activity and then down to the patient. Okay, so that's the idea. It's easier in very distinct pathways. So in the surgical side, costing is much more accurate because it's much more distinct. Okay. In the medical side of things, so in general medicine or acute medicine or any of the non-procedural stuff, okay, so the acute ward-based medicine, it's much harder because you can't quantify to the same level the intensity of contacts. You can do prescriptions, you can do drugs, that's fine, but you can't say how much nursing intensity or how much medical intensity a patient has, because we don't record every visit, every contact we have with a patient. So again, there is a little bit of it's not as accurate as we like. So you have your non-patient costs, you have your kind of all your overheads. Okay, they get divided up by patient, and this is where you get your fixed and variable and your overheads and stuff like that. So you have your patient-facing costs, your ward costs, theatre costs, radiology costs, pathology costs, drug costs. They can all come from the different systems. Okay, and then you can divide it down to a patient. Now, how you do that depends on how how much granularity your data shows. Okay, so some places have got really granular data, and the more electronic and more digital your pathways or your systems are, the more granular data. Okay, and what you can do is divide the cost of the ward by the number of minutes on the ward. Okay, again, it's hard to do that down to how many contacts you do, but you can get a broad idea. The number and type and cost of scans, again, if your radiology systems are online and digital, which most of them are now, that should be easy. Pathology tests can be costed. Drug costs, again, with EPRs, you can get costed. Okay, so that's how they try and do it. And then they do medical or consultant cost allocation, based on activity, and then you can divide that again by the weighted length of stay or the surgical time, or and you divide that cost up by patient. Okay, so these are examples. What you need to do is make sure that the data the PLIX team are getting is accurate, and your consultant or your medical costs, your nursing costs are all, your theatre team costs are all accurate, and you get a good idea of how they divide that up. We found lots of issues in how they were dividing up our data and how they were allocating it out, and it didn't quite. They didn't believe that, for example, we might have a plastic surgery list and only have one general anaesthetic, which the anaesthetist was involved in, all the others were locals, because it's a really bad. It's a waste of time for us. But they didn't understand that was how they book things these days. So what you can use PLIX for, you can use it for business cases, and I'll show you how we've done that in some places. You can do it for service redesign and reconfiguration. So if you do a service redesign, you can show that it actually costs less per patient to do it this way. You can do benchmarking. So again, one of the things that you can do with PLIX is go, look, there's no point looking at the stuff that's really niche. We do complex ECMO, or we do esophagectomies. Now, there's no point looking at those, because all you need is, you might do 10, 20, 30 a year, but all you need is 2 or 3 to have big length of stay or have a few complications, and that'll skew your data completely. What you need to look at is your bread and butter stuff. For us, it'll be things like, in my hospital, it'd be like appendicectomies or tonsillectomies, or something that's really, you do lots of, high volume, low complexity, ideally, but even something that's not so high volume or low complexity, but that you do a fair amount of. And then what you can then do is then look at, are you making money on it? And if not, why not? Because you should at least be breaking even. Patient level costing information systems. So it's basically the software program that drives the costing system. That's basically what PLIX is. Okay, Viola.
Thank you. Yes, I wanted to ask, but the software for PLIX is very expensive. So is there how many, trusts are using it? And are there enough trained staff? It's really...
So PLIX is now mandatory. So every hospital, every acute hospital, definitely, and most mental health hospitals are using PLIX, some form of patient level costing. Now, depending on when you bought it and when you took it on, the granularity and the kind of the detail that you'll get the PLIX detail in will vary, and depending on what information is coming into it will determine how useful it is. But everybody has to have PLIX now, and there is a PLIX department in every hospital, particularly in the acute sector, and even in the mental health sector, they all normally sit within the finance teams, and they'll be able to give you access to data.
So my next question is, so is there a submission? Is it all fed back to NHSE at the data, or is there any overarching body that looks at PLIX data? Does it need to be submitted, or is it just within the hospital itself?
So it's all submitted. So every year, as I say, to develop that whole the tariff system, okay, they have they submit the costs. All the costs for every HRG has to be submitted in to NHS England, and there is a dashboard that's available. It's on the same kind of portal as a model health system. There's a similar type of thing that sits that has a Plix dashboard that you can compare the cost of delivering your care with another organisation. Now, depending on the kind of interface, so our data is not accurate enough for it to be put onto the dashboard from my hospital, which is really irritating, but it's something we're trying to work on to make sure that we can get that sorted. But you can look at what the average cost of delivering a service is in the country based on those organisations that have it. And then you can look at how much it costs you to deliver that service and see why is it that you're not making money? Is it that you are losing money because of, is it a facilities thing? Is it a pathway problem? Are you seeing are you seeing patients too many times in the pathway? Is it that their length of stay is too long? What is it that's causing the problem? And you can look into that. And so it's not about so when Plix first came out, a lot of clinicians were very concerned about it because they thought that if it was going to show that we were going to lose money on a particular operation or area, they wouldn't deliver that area. Now we can't do that, and it's that what we've had to do more recently is reassure people. But also the first step in all of this data analysis is making sure the quality of data is accurate, and that's what happens is that the first time you look at Plix data, you'll go, well, that's wrong, that's wrong, that's wrong, inevitably, because unless somebody's already done that for you. So if you've got somebody who's already into it in your department and will then go through it and go, yeah, so, why have you got this patient under, gynae when it actually was it was a general surgery operation? There will be errors because it's all, all based on the data you put in. And if you don't put the right data in for whatever reason, then you can get some really weird, spurious stuff out. So the first thing to always do is to get involved in it and then check for data quality, look at where the problems may be. Is it something to do with us as clinicians not putting the right data in, or is it something to do with the systems feeding into it? And then you can go, right, now that we've made sure we believe the data, because that's the first thing, you've got to trust the data. Now we can go, look, where is it? Where are the problems? Okay, and that's where you can do a lot of work.
Oh, thank you. That was really helpful. Thanks. Okay. Because Plix, the whole thing was just the amount of volume of data that was there to make sure what was accurate, and then for the clinicians to actually input it can be quite tricky.
Yeah. We shouldn't be inputting it. What we can do is just help with the data quality aspects of it, and then look at it that way. That's the best way of doing it. So this again, example from Leeds, they're very good at this kind of stuff. So they used Plix data to show that this new surgical technique was going to be better overall. So whilst they looked at whilst this Urolift procedure was more expensive to do because it had a high consumable cost, because it can be done as day case and had less complications. It didn't have the hyponatremia and TURP syndrome and all those other things that came with the standard TURPs. You actually save money overall, and you can the pathway and you can implement this and that's the way of doing it. Okay, this is the kind of, so every Plix portal will be different. This is the national benchmarking one. You can get so Plix data is done by there's a Plix team. So there's a costing team within your organisations. They normally sit within the finance team and they look after it. It takes data in from clinical coders and from other, if your theatre management systems, your EPRs, your prescribing stuff, your pathology systems. It will take all the data in from all those different areas and put it in and divide it down to patient level. You will all have a Plix system in your organisations. We tried giving every consultant, we tried giving them access to Plix data, but they didn't really know what to do with it. So now we've done it so that we try and educate them first, and then get them to come and have a look at the Plix data, and then we try and take them through it first so that they understand it. We then go through the issues, data quality issues, and then we go into a bit more detail. So they are finance trained. They are finance costing teams. So most of them are accountants of some sort. Okay, the Plix team members are mostly, so they will take in the data and process it in a certain way. That's why they need clinical input to help with that. Now, some organisations have that built in. So Leeds have a system that got a good relationship with their clinical teams, and their Plix teams worked well together. Nottingham have got their Wave program, which does a similar kind of thing. Leicester, we're trying, and we go through phases where we do a good amount of work and then we kind of fall behind a bit. So Manchester University's got a great Plix team, and they're really keen to listen to clinicians, because I know the Plix guys there. So it really does depend on the organisation, but they're always really welcome clinical inputs, because they want to make sure the data is accurate as possible, and they want to make sure that all that work they're doing is used to improve the situation and to improve the quality of care that patients get. But you can do lots of work with it. Any questions on payment systems, costing, Plix, coding? I think I had a question further up that I've missed. Coding. No, they can often so in spells. So things like past medical history and comorbidities can be done in each spell. The problem lies where you've got people being discharged and coming back in. So, for example, one of the problems we've had in oncology is that we've got patients coming for day attenders to oncology, and because the oncology team know their patients really well, and so they don't write all their comorbidities each time they come, but because they're officially admitted and then discharged rather than as an outpatient, they have to be coded each one, and we can't. Some systems, EPRs, will allow you to kind of just transfer your past medical history from one to the other, from one episode to the other, but ours doesn't yet. So if they don't document each time they come in the past medical history, even though they know these patients, they know them really well, it doesn't get coded. So that's some of the problems you might have with coding. Kate?
Can you hear me okay?
Yes.
Great. In terms of, sorry, going back with Plix, we've covered that there isn't an infinite pot of money. So if we all did the coding and the Plix perfectly, then actually there would still be an underfunding compared to what we were expecting, because the pot of money is not infinite. So where I can see that there is an advantage in having Plix done well, but if the advantage is not to increase the funding, then what would you say the advantage is?
Cost. Decrease the cost. You can see where your cost problems are, and you can see where, I'll show you when you come to business cases, where you can really look at where your problems are. So if you see that you're losing money on a procedure or a particular diagnosis or particular area, you can then look into it and go, why is it? Is it because my length of stay is too long compared with other people? Is it because and what do we need to do that? Do we need to change things? Do we need to change how we deliver our care? Or is there something else going on? Is it being coded wrongly? And actually, we're not losing money. We're just doing more complicated stuff than was appreciated. And so again,
coding is about being paid, whereas Plix is about reducing loss.
Yeah, so they're all intricately related. But yes, I mean, coding, because it underpins all the Plix stuff and underpins all your mortality figures and all of that stuff, it's really important to get the coding right. Yes, it does, and historically, it's always been the driver about being paid. Then it's about reducing cost. So yes, and you are, to keep it simple. Yes, coding's about income, Plix is about costing, is about expenditure. That would be the simple way of looking at it, but it's a bit more complicated and nuanced than that. So it's never about it's not about having clinicians trained for data printing. It was never about data inputting. It's about documenting clearly. It's about making sure that, you know, the same in a similar way to coding can only work in a similar way to the medical legal system. Okay, the reason why possible can't be coded but probable can be coded is in the same way as if you were put it in a court of law, then possible means you're less than 50% sure, probable means you're more than 50% sure. So that's because and this is all, you know, it's all related to the medical legal system indirectly anyway. So it's not about making sure that you have data interpreting purposes. It's making sure you documentation for your own good communication and good documentation. That's basically what it is. Okay, and we need the IT systems to help us do that, and that's key. And yes, we would brilliant if we could all do that without us having to be overly aware of it all. But IT in the NHS is not that great because it's because of the confidentiality of it, the fact that it's so expensive because the companies that need to bid for these things have to go through so many hoops to be able to be accepted onto the frameworks that that are involved in this, essentially. So yes, we want the IT systems to talk to each other, and we are getting better at that. It's just that at the moment, the way they've been designed mean that often IT systems are designed for one purpose, but it's the other purposes, the background purposes that that matter. And what you'll find is that most systems, digressing here, most systems are either designed for the reporting function, okay, or it's been used for the kind of inputting function, the user interface, okay, and we haven't got a system that does both really well. Okay. No, so I'm saying the documentation, if you do it right for clinical care, and it's really it's competent for doing clinical care, then it'll be okay for coding. So the level of detail is important, and that's the key thing. If you use SNOMED coding, then the data you get out of it is really good. So, for example, SNOMED coding is the reason why you're using SNOMED coding in the future for all EPRs is because once you've coded it, then you can very easily see how you can do analysis, and you can do your kind of quality improvement projects, your research data is is much easier to get hold of because you've got clear fields. So it is all about the clinical care. And if you know, with my medical legal hat on, then it is about making sure that your documentation is really accurate. Now, the number of times I've done a medical legal investigation and the documentation is so poor because, you know, you have CT scan, then you have the operation note. There's no documentation about the discussion. There's no, and that doesn't necessarily impact the coding per se, but it does impact. It impacts both, because if you have a CT scan and you don't have a result, but then you have the operation, you cannot then code the result of the CT scan. But if you document the CT scans show this, I've discussed with the patient, we're going to go and do an operation, then that can be coded, but it also is really important for clinical care and good documentation of your processes. So it works for both. As I said, I'm not trying to get people to do stuff just for the finance stuff. It is about making sure we do stuff for all aspects of our clinical care and being aware of the financial implications that has on everything we do. So I would never say we need to do stuff because actually it's good for finances. It's all about benefiting it from a clinical point of view. If there are benefits of finance, that's great. Okay. Let's take another 10-minute break. I'll hang around again for questions if you want, and then we're going to come to business cases as our final section. Okay. Let's have a slightly shorter break so we can get this done and finish on time. If we take this, I'll come back at 5:02. If that's okay. Quick. It's enough to make a cup of tea, grab some bites to eat, and go to the toilet if anybody wants to. And then we will finish on time at past. I will stay online for another 15 minutes after that if you have any questions, but I'll try and aim to finish at past. See you in 5. Okay, final stretch. Business cases. So the idea of this next section is to try and put together all the things that we've talked about already, to try and put together a business case, a quality improvement project, or a rationale for doing something. Okay. What we're going to talk about now is the official way. Every organisation will have slightly different processes, will have slightly different paperwork, will have slightly different hoops you've got to jump through. And don't get me wrong, there are lots of business cases that are done poorly that get approved. And so there are business cases and they're business cases. So some business cases are the organisation wants it and you've got to just fill in some paperwork to tick the box. Okay. There are others where, and this is increasingly going to be the way, where you're going to competing and it's about prioritising. So in very few scenarios is it that the idea that you come up with is a bad idea. The question is, when there's limited funding and limited amount of resource available, which of these business cases need to be prioritized, and which is going to have the most benefit and deliver the most value for money. Okay, it's not to say that your business case is not good, but the idea is it's a bit like Dragon's Den. It's a combination of Dragon's Den and the X Factor. You've only got a certain number of slots, so you've got to do your pitch and you've got to do it well. Okay, and if you can demonstrate you've kind of thought about it and you thought about all the real different options and you've got a clear process that's on display, then it's easier to push forward. Okay. So the next question is, what actually is a business case? It is a document. Generally, it's a document that you fill in to ask for a particular amount of resource or to deliver a different way of doing something. Okay, and your business case if you want more resource. So whether it's money, staffing, whatever it is. Okay, that's the main kind of purpose of business case. But increasingly, it's also being used to look at retrospectively how a thought process came to, or why a decision was made. So, for example, if you've chosen to do something, it's now increasingly being used to look at, so what was the thought process to get to this point? Okay, and why did you not consider this, and this, which may have been better options? Okay, so there is that side of things as well. Historically, the purpose of business case has always been to drive income. Okay, that's been for 20, 30 years. Business cases were driven to drive income. Now it's about solving a problem. Most business cases have to solve a problem. So when we look at business cases, the most common reason for failure or business case failing is that the business case has been written with a specific answer in mind and hasn't considered any other options. Okay, and that means that it's not felt to be well thought through. If you write a business case to solve a problem, and then you look at all the different options available, and then you pick an option and show why this is the option that's preferred, you're much more likely to get it through. So if you haven't got a problem to solve, there are a small number of cases where you can do it to improve quality, but it has to be a big improvement in quality for not much money, okay? Because otherwise it won't be prioritized. But solving a problem is the key. You've got to show there's a problem, and you've got to then put this as a solution in. It's really important to understand the process of where we're going to be doing this business cases, who you need to get on board, who's going to be looking at the business cases, what hoops you've got to jump through. Because as I said, every organization will have different hoops to jump through. And when we come to the hints and tips later, it's important to look at, are you looking for the right group of people? So who is it that needs to see this? Is it the operations team and the ICB, the commissioners? or is it the education team, or is it a national safety team? Okay, look at where you might be best suited and what process might be best suited to whatever you're trying to do. Okay, I'll give you some examples in a bit of that side of stuff, but understand the process. How many, and in order to do that, you have to have a ballpark idea of the cost of it. Okay, if it's going to be a multi-million pound thing, then it's going to have to go all the way up to not just ICB but NHS England or whatever the new entity will be. Okay, if it's a very small thing, you might be able to do it within your own directorate without getting too much. There might be a lot fewer hoops to go through. And then there's been a few business cases where we've had the idea, we start writing business case, and they've gone, actually, we can do it from internal funding. We've already got the funding for that. We can just do it. And you put your rationale, and you've just sold it to somebody, and they go, well, that's a good idea. We'll just do it. So there are different ways of doing it, and it's important to understand the process early so you don't do too much work for it, essentially. So a business case needs to have all the things, the what, who, what, where, when, how, all that needs to be in the business case. But there is a good structure around for it. And most business case pro formas, forms, applications are based on this system. It's the public sector better business cases model. Okay, it's called the 5 case model. Okay, so the 5 components. Is it needed? Which is what strategic case is. Is it value for money? Okay. Is it viable commercially? Is it affordable? And is it achievable? Okay, so strategic case, economic case, commercial case, financial case, management case. Okay. So they're the key things. I'm going to miss the next slide and come back to that because it's a good summary slide. So us as medics, clinicians, will be focusing almost completely on the first 2 bits, which is the strategic case and the economic case. Okay. The other bits you'll probably need some help with, but we'll touch on them in a little bit as well. So you need to put into context why this is important. So what's the strategic context? How does it align to your organizational aims and ambitions? So you've got to somehow show each year your organization will come a plan, an idea, things or its priorities. It'll have some word of saying what its aims are for the year. Okay, for example, ours is like best possible care and financial stability. I think it is for us this year. That's all we're looking to achieve. And so how is your business case, your proposal, going to align to that? Its aims, ambitions. The other key thing is you need to make sure that nothing in your business case is going to be so often that you get like a pre-business case shortlist and you go, is anything in your business case going to negatively impact any of the key performance indicators? Okay, so whether that's one of the key targets. So mental health have got various targets in the acute sector. You've got various targets in terms of 18-week waits, 2-week waits, any of that kind of stuff. Is it going to negatively affect any of those things? Because if it is, and you haven't put mitigations in for it, it'll just get dismissed. So just be clear when we do that. And this is the bit where you've got to really sell your case for change. Okay, and so you might want to put in your current situation. Okay, what the situation is at the moment, your existing arrangements. Okay, and then why do you think it's a problem? Why is there a problem? So that can be done by using benchmarking. So whether it's the model health system, whether it's CQC report, whether it's some other sort of benchmarking, quality mortality indicators, getting it right first time, we're all quite good. NICE and Royal College recommendations probably don't have as much weight as they used to, mainly because they are coming up with so many recommendations at the moment, both NICE and Royal Colleges, and they are nice to have, but they are very few of them are absolutes. So because there's so many of them, they don't have as many as good a weighting as they had previously. Mortality reviews and root cause analysis are also quite good, though they are coming a bit out of favour as well, mainly because we've gone to the PSERF type way of looking at analysing stuff. But again, you just need to build up your case for change. So I'm going to try and give you examples. As I said, the ones that are most of mine, which are theatre based, are anaesthetic or theatre based. So this was from the model health system. Okay, one of the things we used was they measured is desfrane's a particular anaesthetic gas. It's really bad for the environment, and we were really high user of it in our trust. So I used this. So when I became sustainability lead, about 6 months later after this, I used this graph to go, look, we need some more pumps. So I got some different type of pumps to do a different way of delivering the anaesthetic, which is more, in theory, more environmentally friendly, but it also has the benefits that this desfrane had. So I used this to justify that we were such a high user. It was quite a high thing on the NHS England's radar. So and there was a specific sustainability fund to apply to, and so we used this to get some money for that. This is things like, this is where Plex comes in to a degree. So this is from the model health system again. It showed the number of patients that had a length of stay of less than 2 days for an emergency appendicectomy. Okay, now we have less than 15% of our patients with a black line, less than 15% patients having a length of stay of less than 2 days. Now, if you look at Plix, you can go and just look at the cost across the stay, and the peak is normally the operation date, because it's the most expensive day. And you can see that we could show that it wasn't because our surgeons are not very good and we had a high complication rate or anything like that. It's just that our patients weren't getting their emergency appendicectomies until day 2. So we were never going to, a high proportion of our adult patients weren't getting emergency appendicectomies until day 1 or day 2. So already in for 24 hours, if not 48 hours before they even got to theatre, and so forth. So the length of stay was always going to be longer. Okay, and we can use that to then go, look, we need to increase our emergency theatre capacity. So that's what we've tried to do. So you can use the data to push your narrative that you want. Okay. Other things you're looking at is, so your existing arrangements we talked about, your business needs, current and future is all about demand and capacity modelling. So look at what your current capacity is and how things have changed over the last few years, because things will have changed. And then you can predict then how it might improve over the next, how things might change in the future. Okay, so if we were doing X number of appendixes this year, what's our population growth? What's the likely change over the next few years? Well, it's changed by 2% every year. We've increased the numbers. It's probably going to increase by at least 2% the next few years. Okay, so you can look at that and just plan your demand and capacity. Okay, potential scope and spending objectives are similar in that, am I doing this business case proposal to build a whole new theatre complex, or am I doing it to increase the staffing and use the existing theatres better over in the evenings and weekends? Okay, so that's the scope. Is how much am I doing it? Am I doing a big new complex, or because obviously that will change what the number of hoops I've got to go through and where my spin's going to be. Okay, how am I going to sell this or narrate this? So that's the scope of it. Spending objective is it staffing? Is it capital building? Is it consumables? What are you trying to spend the money on? So that's what your spending objectives are. Constraints and dependencies. So constraints are things that are going to limit you. So generally it's going to be estate space. So whether it's you're trying to put an extra clinic on, or whether you're trying to put extra theatre lists, sheer number of theatres available, or space for clinics, or inpatient beds, all of these things will constrain what you can deliver. Okay, so that's generally a major constraint. But availability of, I don't know, other things may also limit your constrain you. A dependency is what other projects or other things are dependent on this project. So in Oxford, they recently, well, not recently, this is a few years ago now, built a day case orthopedic centre. Okay, so the business case of radiology, so the one is dependent on the other. Okay, you can't have a functioning new orthopedic day case centre without the radiology backup machines and staffing to operate it. But they were two different business cases, and so but one's dependent on the other. Okay. And here's where the terminology gets a bit weird. Okay, so benefits are things that are going to positive things that will happen. Okay, risks are things that negatively may happen, but as a risk may not happen. There's a potential they might happen. And there's this random word called disbenefits, which you might see in some of your forms or stuff like that. It's negative things that will happen. Okay, so disbenefits are bad things. So a few years ago, we used to do these business case pitches. I don't know how we describe them, but basically people would come in and pitch business cases, and we'd go through them and highlight the issues that might come up. And so we had a radiologist come on who was developing and putting a new business case for a new way of doing breast screening program, and it was doing an injection rather than the standard mammogram, I think it was. And it sounded great, higher specificity, high sensitivity, all good, apart from the fact that it takes longer to do. Okay, and the original business case hadn't factored that in, and so you kind of go, well, if you're going to be seeing less patients, that's going to be a disbenefit. So unless you factor that in and either increase the capacity or put more sessions on, you're going to build up. Your screenplay won't be able to cope with the demand. Okay, so that's a disbenefit, and then you've got to put a mitigation in for any disbenefits in. Okay, so yeah, so that's all of those things. And if you are unsure how to do things like demand and capacity modelling, I mean, this is an example. You look at your last 2 years, the numbers, look at the change, and then forecast how it's going to go. This is from an existing business case that I found online. I've taken the numbers out, but this is what they did. Okay, they looked at the number of CTs that they were doing. This is for radiology, number of different modalities, and then looked at how much they were increasing, and then and did a forecast of how that was going to work. Okay, then they did a capacity, which is number of additional lists you'd need, number of patients seen on lean lists, and how many additional lists per year you'd need to do that. Now, depending on the payment system, the reason the bits in grey is that it depends on the payment system whether you get this additional income or not. Okay, but you can factor that in if it is additional income. Sometimes it's not. Okay, so that's demand and capacity modelling to see how many more lists you'd need to deliver the change in demand. And it's always worth planning a couple of years in advance. There's nothing worse than getting one business case approved and then within a year going, actually, that wasn't enough, because the likelihood of you getting another business case approved so soon afterwards for a similar thing, for a similar problem, is low, because they'll go, well, why didn't you think of it when you factor that in when you did your first business case? Is that all right? Okay. So, the economic case. So when you're writing your business case, you are, if not the expert, one of the people who know a lot about your area. Okay. And you know what will work and what won't work. There will be things that you dismiss out of hand because you know it's just not, as a non-starter. Okay. However, the people reading your business cases may not know that. They may not be clinical. They may think of something that's really obvious, but you'll dismiss because it's not a non-starter. Okay. If you, in your long list, if you put all the potential options, however stupid and however, unrealistic, then you can show that you've thought of all of them. And so if somebody comes back to you and go, why don't you think of this? You go, well, we thought of that and we just dismissed it because of this reason. And then you think of all these things, and then you have your assessment criteria. And essentially what you want is, have you seen job descriptions? Have you seen any kind of job description for roles? You basically have your essential, your desirable, same kind of thing. You have your assessment criteria. You have what you absolutely need and what you'd like as bonus. You absolutely needed what's called your critical success factors and the desirable extra bonuses. Okay, and then you do your shortlist. So you go from your long list down to your short list. Now your short list are things that are potential options, and they must you realistically need three or four, and it must include like a minimum, do minimum or do nothing option. Okay, because that's that you need to show that. Okay, and why that's a non-starter or whatever. Okay, and then you look at the qualitative benefits of each option, and you look at the cost of each option, just so you can get a ballpark. You don't have to go detailed, just ballpark of what it might cost, okay. as part of your appraisal. Yeah, and then you can select your preferred option. So there are lots of different ways of doing this process. Okay, there isn't a absolute way you have to do it. It depends on how you're doing it. Okay, but you should do a qualitative appraisal, which is going to get the best benefit, and then one's going to be the cost appraisal. Okay, if you are struggling to come up with options, then what's been suggested is to do it this way. And I'm going to use, because there's a whole, I've used this example for about 5-6 years now, and when I'm talking to a group of people that are very diverse in types of nature, I use the high-speed rail as my example, okay, because everybody has an idea of it. So the problem that we're going to try and address with this business case is lack of capacity on the UK rail network. Okay, so that's that's the problem that we're trying to sort, particularly between London and the rest of the country. Okay, so the scope is the what. Okay, so the minimum thing would be to improve the infrastructure between London and Birmingham. Okay, the maximum would be to London, Birmingham, and then up to the north, west, and up to Leeds. Okay, so that would be your maximum. An intermediate would be to do one of those arms. So in this example, it would be London, Birmingham, and to the northwest. Okay. The how is how you're going to do it. So the scope could be having extra theatres. We could go up to building a whole new theatre complex. It depends on how you want to do it. 1 clinic, 3 clinics. How you're going to do it is about so in this example, it's about refurbishing the existing tracks. Is a minimum. Maximum is building a whole new track, and the intermediate is a mixture of the two. So some parts you refurbish, some parts you build new. Okay, so you do minimum, intermediate, maximum. Who, in the clinical scenarios, it will be who's going to staff it. Is it going to be is it going to be consultant led? Is it going to be nurse led? Is it going to be somebody else led? Is it multidisciplinary? So if it was a clinic, you could have a consultant as your minimum. Intermediate could be a consultant and a specialist, or a consultant and HCA, and a maximum could be a multidisciplinary clinic with different specialities, including some of the allied healthcare professionals, depending on the nature of it. Okay, so you can have a one-stop shop. So you can who is that? Okay, and in the scenario of the rail network, it'll be local, national, international contractors. When would be how you're going to implement it. So is it going to be a pilot? Is it going to be a gradual phase rollout? Is it going to be a big bang all at once rollout? Okay. And for the railway network, is it you're going to build one, then the other, or are you going to build all of it at the same time? Okay. Funding is whose budget is going to come out of? Is it going to be coming out of the capital budget? Is it revenue budget? Is it going to come from commissioning, or is it within the department? Where is it coming from? Is it going to be some sort of private, public, co-sharing? It could be any of those things. Okay, and so you kind of put these down, and then you basically highlight in red and say which ones are non-starters, not viable, do not meet the minimum criteria. Then you have in yellow, you have things that are viable but not preferred, and in green you have your preferred options. Okay, and they are independent to a degree. Okay, and then what you do is you just put your rationale down below it, and it shows you've thought of all the different options, and you've thought of why you've got a good rationale of why you've chosen what you've chosen. Okay, so that is a recommended way of doing it if you struggle to come up with different options, different ideas. So, strategic case is why we need to change, what the existing arrangements are, future needs, benefits, and all that kind of stuff. The economic case we've kind of come up with, it's why you've chosen the option you've chosen, what the option is that you've chosen, and that kind of stuff. So the commercial case is all about the procurement process. And this is where you've got to get in your procurement teams involved, because if you're buying anything or procuring any kit, then there are lots of procurement regulations. You've got to do it in a particular way. It depends on how much you want to spend, how much the cost is. Depends on how much of a procurement process you need to go through. There are generally a few different ways of doing it. You can put it out to open tender. If it's above a certain amount, you've got to put it out to open tender, which means that any organisation that is able to deliver those services can bid for it, and you've got to go through you need to have clear criteria on what you're going to judge them against, because then you've got to justify it, and it can be quite a laborious thing, because most of the time there's very little difference between them, and you've got to be clear why you've chosen one over the other. It's good for getting value for money, as in, because you're opening out to a wide field, you'll probably get a cheaper option, the cheapest option available, or the for what you need. Okay, or you can do this thing where you kind of you select some people and you trial them. You kind of get some trials, and then you do a direct award to the preferred bidder. Okay, but there are caveats to that, and you've got to show why you've chosen that. But that gives you more, as a clinician, a bit more input into what you've chosen. You've also got to be aware of contract issues. If you've got an existing contract and you want to get something, so syringes, I'm just going to use syringes. If you want to get a special type of syringe, but your organisation has a contract with a company to deliver all their syringes, if they're already delivering that type of, or if they have that syringe in their repertoire, you may not be able to get your fancy one. You might have to wait and then put your requirements into the next procurement process for trust-wide syringes. So just be aware of the contract issues around that. Personnel requirements are all about, you've got to think about, if you want, it's working time equivalence is how we work it out on. If you are looking for a consultant role, then the standard you put into, so when you're kind of working out the cost of delivering a extra clinic every week of the year, we do consultants on a 42-week basis. So we are you're required to deliver 42 weeks of clinical care, and so to do a weekly clinic, you might need 1.2 working time equivalents of consultants. Okay, so you need to factor those type in. Anybody on the agenda for change contracts, which is anybody other than doctors and dentists, are paid kind of 37.5 hours. So if you need somebody to work, longer hours, so 12-hour shifts, for example, then you might need more than one working time equivalent, and do they need weekends and overnights and stuff. So HR are quite, or people services of HR, whatever you want to call them, are quite good at giving you those kind of templates to work out how many working time equivalents you would need when you're factoring this in. And then other things like, you've got to make sure you put enough leeway in, because if you are looking for a consultant or a consultant role, and you need to put it out to the market, you've got to get Royal College of, you've got to get, obviously got to get approved the job from a finance point of view, then got to get Royal College approval, then you've got to advertise it, interview, and appoint. And most people have, you can interview for a consultant job within 6 months of your CCT. So you may not get somebody into post for a year, and so you've got to factor that into your kind of personnel requirements and your business case. You've got to have realistic timelines of how you're going to do this. Contract issues are all related to just making sure that there are no conflicting contracts. So we had an issue where we bought a piece of equipment that had a particular computer, say I'm going to say Dell, built into it, but the rest of the hospital had runs on HP computers, let's say, and so there were massive issues trying to get them integrated into the network, and we had a 2-month delay while IT had to sort it out. So just be aware of contract issues and conflicts that may arise. Where's the money coming from? Is it who's it coming from? The money is it coming from ICBs? Is it specialised commissioning? Is it from education funds? Is it from something else? And then if you said you're going to save X amount of money, over how long realistically is that money going to be saved? Is your savings going to be achieved over? If we're going to reduce the cost of delivery of service, how long is that going to take based on what you're the cost of implementing it all? How's it going to, but that's where finance comes in and really good at that kind of stuff. How's it going to be delivered is all about, your rollout. So I know some places so for example, Poole Hospital managed to get, I think it was an MS charity or a particular charity to fund a nurse specialist for a year on the agreement that providing they met certain kind of quality improvement metrics, then the trust would then do the ongoing funding for it. So there's different ways of doing that. So how's it going to be delivered? And then that's all to do with rollout. The impact of service delivery is a combination of things. There's one is around what you're going to do while you're implementing it. So what's the impact during the implementation process? If it's a big implementation, are you going to have caveats? Are you going to have extra staffing in? Are you going to have something else during that implementation process? But also, is it going to impact other services? So, for example, if you're going to run a extra clinic, a specialist movement disorders clinic that previously been seen in the general neurology clinic, does that mean that you're going to get more space in the general neurology clinic, or is there going to be less space because you're not going to be delivering it and you need other people to deliver that general neurology? What is the impact on the different services in that time? It's just things to think about. Okay, and if you show that you've taught about it, it looks better. Try and get anybody affected. I don't like the word stakeholders, but try anybody that's affected by your business case. So other specialities, other AHPs, nurses, whoever might be affected by your business case, get them involved. The more different areas that support a business case, the more likely it's going to get through, and the fewer barriers people put up. Okay, so get them involved. Timing is important. Small business cases, particularly ones that are capital based. So if you're looking for just one-off purchasing stuff, February is a great time because often some capital projects that have underspent, and if you just need a small amount of money, then there's normally a little bit of money floating around for bits of furniture, bits of kit, because they once the capital budget goes, they try and spend it all. But if you're trying to set up a whole new service, then it's sometimes easier to start from the new financial year, because if they've run out of money this year, you might be able to start and incorporate it into the discussions from the kind of with the commissioners early on. Other things that are useful are education funds. There's lots of education funding out there, and again, particularly if it's one-off funding, education funds are quite good for kind of revamping resident doctor areas. We managed to get a whole new kind of anaesthetic training hub from education fundings that we were never going to get from our operations teams through normal processes. Look at, we may not have as much system versus specialised funding anymore. but if do you go to the ICB, do you go to NHS England? Who's going to be the most affected by it? Which kind of group of patients are going to be affected by it? They occasionally come with patient safety funds or digital transformation funds, little pockets of money that come out for specific purposes. So we've got some money for our electronic consent implementation and another sort of electronic bit of implementation. There's a lot of money at the moment for people who haven't got EPRs for implementing that. So there's all that kind of stuff. Every so often, NHS Resolution comes up with a patient safety fund to try and get people to improve patient safety initiatives. The other thing you can do is then combine it with a larger business case if you've got a smaller one, and it's relevant. So yes, that's it from me. Any questions at all? It is a whistle-stop tour. It's, again, by no means a definitive, all-encompassing, but it should give you an introduction, an idea, a way of doing more and going back to your own organisations and investigating what's there. I'll hang around if you've got any questions for the next 10 minutes or so. Viola?
Thanks. I just wanted to thank you. It was brilliant, summary of everything. It was so helpful. So thank you. I just wanted to ask, the question I wanted to ask is, how do you use finance to reduce and improve the DNA rates? Do you have any information on doing that? I mean, in terms of a financial aspect, or because that's what we're trying to do as well in gynae. We have huge capacity, but DNA rates as well. That must be across all trusts, I'm thinking.
Yeah, I mean, you don't look at finance per se, but you can use the financial data to try and address it. So is there a particular subset of group people that are struggling? Is it from people from further away? Is it